All right. Hi, I'm Dr. Jared Gardner, and I'm here today with my awesome dermatology residents, and we're going to talk about some bacterial and a few fungal infections and go through some unknown slides. All right. So who wants to take this first one, case number 1?
All right. It's a sheep biopsy.
Mm-hmm. And from low power, not real exciting, right? Not a ton of inflammation. There's a little bit of extra keratin up here, maybe some spongiosis. So what do you think the diagnosis is, or what kind of differential would you have in a case like this?
Like the path that's not really specific, but like a normal skin differential.
Yeah. What kinds of things do you think of when the skin looks relatively normal?
Like ichthyosis vulgaris, tinea, vitiligo, amyloid sometimes.
Good. Those are all good things to think of when the skin looks normal or relatively normal. I also sometimes think of TMAP, telangiectasia macularis, eruptiva perstans, a subtle adult form of mastocytosis. Here, I think there is some sponge. So I would say my first thought here is that this may be a sponge derm. It surprisingly has very little inflammation. One thing, though, when I see sponge derm that has, or if I see any skin that has a thickened layer of compact orthokeratin. So see, the keratin here is thick and dense, and there's a little bit of para in there, but it's kind of thick and mostly just pink without nuclei. What should that make you think of?
Maybe tinea.
Yeah, dermatophytosis, tinea, often produces that thick, compact orthokeratin. Sometimes it's sandwiched between a layer of para, like here, there's ortho and then like dense ortho and then para. The sandwich sign is supposed to be pretty useful for dermatophytes or tinea. I feel like most often when I see the sandwich sign, it's not tinea. So I feel like you can see that in resolving dermatoses where there was a rash that was inflammatory like sponge derm, and then the patient comes for a biopsy 10 days later or something, and then by that time it started to resolve, and so the layer of para has been pushed up by a layer of more normal keratin, all right? So here, that is the diagnosis, is dermatophyte or tinea. And look, it's a little hard to, okay, it's pretty hard to see. Some of these slides, of course, it's going to be hard to see because we're looking at very small things. There's a little tiny circle there with a little dot in the middle of cytoplasm. That's the cross section of the fungal hypha. And here's another hypha right here that's running kind of longitudinally. And you might be like, really? Well, some people say that they can make the diagnosis of dermatophyte just on H&E. And there are times like this where you can really see them. And sometimes they turn a bluish tinge, but in my experience, the tinea, dermatophytes are usually totally clear, even when there are a lot of them, and they're often very hard for me, at least, to detect with confidence on H&E. So if I have a doubt, I do a PAS stain. Okay, but you can, in this case, very nicely see the little holes. And to me, the compact orthokeratin is one clue. What are some other clues microscopically to dermatophyte? When should we think of dermatophyte fungus? Oh, here, look at this. This is a nice longitudinal. Oh, it says this is the max. There's a longitudinal hypha right there, right there. And again, some little cross-section tubes. But it's kind of subtle, even in this case, which is florid. So what other things, aside from compact ortho or maybe a sandwich sign, what other things can make you think of dermatophyte?
Just like the normal skin differential. If you're just struggling, like nothing jumps out at you.
That's true. But there's one other thing. If I see sponge derm with one extra finding, does anyone know what thing, if I see in sponge derm, will, at least for me, prompt me usually to do a PAS?
Like a subcorneal pustule?
Yes, exactly. Neutrophils in the stratum corneum. Now, plenty of times I see that in sponge derm, maybe because it's been, impetigonized a bit by bacteria from the skin surface. But when I see neutrophils on top of a sponge derm, a pustule or even scattered ones, unless I've got some other good diagnosis or a reason that it doesn't make sense to be dermatophyte, I'll usually do PAS. I know some people will do PAS on every sponge derm they get. I personally feel like that's a little bit overkill. Then again, maybe I'll miss a case of dermatophyte here and there. I'm not sure. I have seen cases like this one where, look, aside from the compact ortho and the fact that you can, at closer look, see multiple little areas where the hyphae are, there's no neutrophils. There's minimal inflammation. This might not look real exciting. So a couple other things I use are the clinical clues. If you guys as dermatologists tell me, rule out dermatophyte, or that you're thinking about dermatophyte. If you tell me that you put steroids on a rash and you thought it was sponge derm or atopic or eczema, you put steroids on it and it got worse or didn't resolve, that usually will prompt me to do a PAS. If you're telling me your differential includes something that has a ring or annular shape, like if I see sponge derm, but you were asking for granuloma annulare, then I'm going to think about doing dermatophyte. Those are all reasons that will usually prompt me, in addition to the clues I see microscopically, those clinical stories of persistence or worsening after topical steroids, which is, of course, one thing. If you put steroids on dermatophyte, it will flare up, right? And then it starts looking weird and becomes tinea incognita, and then can be really hard to diagnose. And I've seen really severe cases of that where I saw a poor kid in fellowship that had a rash for like 2 years or a year and a half and had been putting multiple different steroids that their doctor was prescribing for them, and no one ever scraped it or biopsied it, and it was just dermatophyte. So let me now switch over to my PowerPoint real quick and just show you an example. Here's an example of, let's full screen that. Here's dermatophytosis, where you have sponge, you have that compact ortho, and some neutrophils and debris. Here in the follicle also. And this is what the PAS stain would look like. You can use GMS if you want. I think PAS works really well for superficial fungi. For invasive fungi, sometimes GMS works better. But you can see the little septate hyphae, and they tend to run parallel to the skin surface, whereas other things like Candida tend to kind of dive down. Dermatophytes tend to kind of surf across the waves. I stole that from someone else, but I'm not actually sure who it is. I feel like it's something Dirk Elston would say, but I can't remember if I've ever found proof of that. And then here's a real close-up view where you can see, if you're not sure, sometimes you see PAS positive stuff in the stratum corneum because serum will be PAS positive. The key to me is seeing either a cross-section round tube or an elongated hypha that has either little septations in it, or that you can see there's a clear hollow center with a thick pink on the outside. And they're very uniform in shape, in diameter. They're very constant in their shape. I find that helpful because sometimes I see pink stuff and I'm like, is that real or not? And you got to decide. If I tell you in my report, well, there's some pink stuff and I'm not sure if it's fungus or not, you may not be real happy with me. I have occasionally done that and said, I'm a little worried, but I can't be sure, and I want you to scrape it or culture or something like that. All right, and this is an example of bullous dermatophytosis. Note the neutrophil abscess. So every once in a while, you can get really excessive spongiosis or sometimes really abundant dermal edema. In a case of dermatophyte, that can cause dermatophytosis. And I remember this case well because it was not suspected clinically, and I even felt like, oh, it's not going to be dermatophyte, and it totally was. And I'm sorry, but I don't have a picture of the PAS here, but you'll have to believe me, there were fungi. All right, so let's go back to our slides. Case 2, any questions about dermatophyte before we move on? Okay. Case 2, who wants to take this one? Let's say we're in the axilla or the groin, a fold site. It's crickets. What do you guys think?
I'll take it. I thought this one was challenging. I thought it was sort of a normal skin differential. Again, there's some compact orthokeratosis.
Right. That's the key right here. It almost looks like acral skin a little bit, but we know it's not because it's got follicles. Although, admittedly, the side of the hands, you can have hair there, and it starts to look acral. But you're right. This is a little acanthotic, and it's got a thick layer of compact ortho. That is such an important clue, not only for dermatophyte, but also for this disease. So what did you think it was then? Or could be?
I couldn't be sure entirely. There could have been organisms in the stratum corneum. These virtual slides aren't the greatest resolution for
yes,
things.
Exactly. So what if there were, which is what, there's some little blue smudgy stuff here, and I'll show you a better picture in a minute from a different case. But what would you think of if you see some little tiny organisms up here, much smaller than dermatophyte or fungus?
Yeah, so if they're tiny, you think about Erythrasma for and if they're larger than Candida or dermatophyte, but yeah, like you said, they are so small here that it kind of lead me away from fungal more into like erythrasma.
Yeah, so I know that they must be here because this slide is labeled erythrasma, and I do see little blue stuff. But even on the best of situations, on a nice microscope with a good preparation of slide, erythrasma organisms, Corynebacteria minutissimum, are tiny, tiny, tiny little thread-like blue organisms. The key to me is especially always, I've never seen erythrasma outside of a fold site like groin or axilla. So when I see groin or axilla with compact ortho, I always look for erythrasma. And in fact, I try to make it a habit anytime I have a biopsy from those sites to look really closely at the stratum corneum to make sure I don't miss erythrasma, because especially as you guys know, people with, a vulvar rash or a genital rash that's itchy and irritating, they're miserable, right? They've already tried multiple treatments and failed. They're coming to you, and they're not, most people are not going to be willing to have a vulvar or scrotal biopsy on their first visit, right? They want to try some other stuff before they get a biopsy in the genitals. So I know that when a patient's in that situation, they're unhappy, you're frustrated because you've tried to treat them, and so I try to go the extra mile to find anything treatable if possible. And erythrasma, as a bacterial infection that's superficial, is actually really easy to treat, right? So it's the one time that even if it's only every once in a while I find it, it's worth that extra effort, just like looking for fungus. I essentially always look for fungus in the groin, unless I've got some other diagnosis that I can put on there or it doesn't make sense. But PAS I pretty much routinely do in genital skin for rashes, unless I see obvious lichen sclerosis or something like that. Because again, it's an easily treatable thing that you can solve the problem right away, and otherwise it's going to be a difficult to treat problem. So this compact ortho, look for candida, look for dermatophyte, look for erythrasma. Here's an example of erythrasma. So again, the compact ortho, sometimes there's a bit of sponge, sometimes a bit of, there's pigment dropout and a little inflammation, but oftentimes, just like that case, the virtual slide, totally devoid of inflammation. And here, you can see it better here. See the little blue wispy guys here? I spent a long time trying to get this picture. This is from my Dermpath Survival Guide textbook. Shameless plug there, but also the copyright does belong to the publisher, but they're giving me permission to use them in teaching sessions. And here's a closer look. That's what you're looking for. Look how, I'm zoomed in. This is a 60x high dry view. Not as high as oil, but higher than the normal high power on a microscope. And I still have to really zoom it in to get these little threads. They often kind of are little clusters, or they run kind of vertically, and they are much, much smaller than fungi. Okay. You can usually see them on H&E, and they have a blue tint. Although I find that sometimes doing a PAS stain, just the stain itself, even though they don't stain with it, it makes them stand out better because the background turns kind of more pink and pale, and sometimes they stand out better from that. So I found that helpful sometimes too. But that's a nice, really nice example of erythrasma. And again, the compact ortho is the clue. All right. Okay.
All
What
right,
about this?
So there's a split kind of just below the stratum corneum. It looks like maybe in the granular layer. And then a little bit of like papillary dermal edema that I'm seeing from this view, and some perivascular inflammation as well. So like a split through the granular layer makes me think of pemphigus foliaceus, staph scalded skin, or Bullous impetigo. There wasn't really much in the way of like solar elastosis, and the collagen looks pretty bright pink and crisp. So I was thinking maybe more like kid skin, either staph scalded skin or Bullous impetigo.
Good.
Plus also the chapter that we're in, infection.
That's always a good clue, is knowing what we're supposed to be studying. But you're absolutely right. And I'll tell you what, from this slide, I cannot distinguish between those three diseases. In fact, this is labeled as Bullous impetigo, but I did not find any evidence of bacteria or neutrophils in the split here. Now, that happens sometimes where they kind of wash out during processing. But normally, to be able to confidently make a diagnosis of Bullous impetigo, I need to see bacteria in the blister cavity, or at least neutrophils usually. Usually, pemphigus foliaceus and staph scalded skin are devoid of inflammation and, of course, devoid of bacteria. Although I've seen occasional exceptions, particularly a case of pemphigus foliaceus that I thought was actually Bullous impetigo at first, until we had the clinical info, because it actually had been secondarily impetigenized and colonized by neutrophils, and really was deceptive. But here you can see that this is a subcorneal split. The separation, like you said, has happened below the corneum and above the stratum spinosum, and you can see that there are individual keratinocytes, acantholytic, falling apart here. So, you know, like usual with a subcorneal split, that's what's happening is there's acantholysis in the superficial portion of the spinous layer. And sometimes it can be hard to tell apart spongiosis and the epidermis artifactually falling apart from true acantholytic subepidermal blistering or subcorneal blistering. So the thing that really helps me is seeing individual rounded up pink keratinocytes, okay? So this was labeled again as bullous impetigo. Let me show you some supplemental images. Here's regular impetigo, okay? Whoa, that was not right. Regular impetigo can have variable amount of spongiosis and edema and has colonies of cocci bacteria, strep or staph on the surface, usually with a lot of serum, kind of crust and some scale. Okay, sometimes it can be hard to tell, is this a sponge derm like eczematous dermatitis with secondary colonization by skin flora, or is this a primary impetigo? And oftentimes when the rare times I see a biopsy that looks like impetigo, because often it's recognized clinically and not biopsied, in those situations I will sometimes say, well, I'm not sure if it's actually the impetigo is the main thing or the sponge derm is the main thing, and I kind of leave that up to your clinical judgment. But I know that since there's bacteria here, either way, you would want to probably topically provide topical treatment or bleach bath, dilute bleach bath or something to get rid of the extra organisms. Because as you all know, even in eczematous dermatitis or other sponge derms, if they're colonized by bacteria, it can make it harder to treat and more persistent. And there's the nice cocci bacteria here. And look, this is not a gram stain. This is an H&E. You can tell because look at the purple color of the normal keratinocyte nuclei. All right, look how tiny bacteria are. That's a neutrophil there. The bacteria are so tiny. And one way to tell bacteria from debris is they're all the same size. They're all perfectly little round tiny dots. This again is a super zoomed in view. It's very difficult to get good pictures because bacteria are so small. Now I know these must be gram positive cocci, even though it's not a gram stain, because what gram negative coccus bacteria would live on the skin surface? Not Neisseria, right? We're not going to see Neisseria gonorrhea or Neisseria meningitidis living on the skin surface. So I know this must be strep or staph. At least as far as I know, I'm not aware of any gram negative. If someone out there is watching this on YouTube and you're aware of a skin surface infection by gram negative cocci, please enlighten me. Now, what about bullous impetigo? Bullous impetigo, you get the same kind of thing, except you're putting the stuff that's normally on the surface of impetigo down in the blister cavity. And here you can see beautiful rounding of the acantholytic keratinocytes and edema here. Again, that's how I know this is not a spongiotic vesicle, but actually an acantholytic subcorneal split, because I'm seeing the rounded up. See how dense pink the keratin gets? That's because keratinocytes are normally stretched out, hooked up to their neighbors with desmosomes, and so that makes their cytoplasm stretched thinner. So when we see it under light microscopy, there's less density to it and more light goes through. It looks pale. When the keratinocytes become acantholytic, and this is true of pemphigus vulgaris, pemphigus foliaceus, staph scalded skin, any acantholytic disease, you begin to see this rounding up in this very dense dark pink color of keratin because the keratin's all bulged up next to the nucleus. So I find that quite useful. And look what we see here, tons of little dots in the blister cavity and neutrophils. So that's bullous impetigo, and there's a closer look. Again, dead, rounded up acantholytic keratinocytes here, bacterial colonies, and neutrophilic infiltrate down there, bullous impetigo. And as a contrast, just real quick, staph scalded skin syndrome, the same basic concept is happening. It's bacterial toxins that are destroying the desmosome attachments and making the cells become acantholytic and form a split. The difference is that in bullous impetigo, the toxin is being made right there in the middle of the skin and leaking right out from the bacteria and directly causing an effect on the adjacent skin. Whereas in staph scalded skin, the bacterial infection is somewhere else in the body, maybe the nasal cavity or somewhere else, and the toxin circulates in the blood and then gets into the skin. So what you see is that same acantholysis and subcorneal split and blistering, but usually with no inflammation and without bacteria, because the bacteria are not here. They're distant in the body. And sometimes, of course, the roof can totally lift off, and you might at first not notice that there's not a corneum here. And if you look elsewhere on the slide, sometimes you can find the stratum corneum totally sloughed and split away. It's very characteristic in staph scalded skin to have that happen because of the diffuse nature of the skin sloughing and splitting. And there is acantholysis and rounding up of keratinocytes. Here you can tell this is happening in the actual granular layer because you can see the purple keratohyalin granules. All right. All right, so what's this one? Case 4.
A
can try this one. I kind of struggled with this. So initially it looks like we have a shaved biopsy, maybe of a mucosal site. There's a lot of like clear cell change up top, and then part of it's eroded and ulcerated to the edge too. My first thought was, is this like PEH with pus, like pseudoepitheliomatous hyperplasia?
Excellent.
It seems kind of up more superficially, but really neutrophils aren't found more in like the deeper areas. It's just kind of like lymphoplasmacytic inflammation.
So what do you think then? That's excellent description and very, very nuanced and subtle thing you picked up on that, like regular when we think of PEH, pseudoepitheliomatous reactive epidermal hyperplasia with neutrophil aggregates with pus, we think of deep fungal and stuff like that, right? Bromoderma, iododerma, halogenodermas. And we expect the neutrophils to be down in the dermis, kind of in pockets underneath the PEH. But here we see a whole bunch of edema and like epidermis falling apart and keratinocytes kind of ballooning and getting real pale and swollen and tons of neutrophils. Then we see the pseudoepitheliomatous hyperplasia. And then down here, like you said, we see a dense infiltrate of plasma cells and lymphocytes. And you're right, this is mucosal. This is probably perianal would be a good site, or genital skin. So then what did you think, or what would your differential be?
So a differential for the top part, I wanted to see if maybe there was candida hiding in there.
Excellent.
But I don't think that would explain everything. And then also, I know we always have to think about syphilis with these like elongate redi and then plasma cells. So
Excellent.
That was somewhere in there.
Yeah, this is definitely syphilis, but you're right. Without the stain, you wouldn't be able to make it for sure. But this is a really nice example of Condyloma lata, which of course is a form of kind of warty overgrowth of epidermis in that I think is still considered secondary syphilis. My understanding of the way it's thought of is kind of an unusual variation of secondary syphilis. I've only seen these rarely in practice. I don't find them very often. They don't, to me, look very much like Condyloma acuminatum, which of course is the HPV-driven genital wart. But they do have kind of clinically look like that. I feel like they tend to be more flat plaque-likes rather than vegetative, kind of, warty looking clinically. I mean, I've seen pictures that look more warty, but I think the ones I've seen in practice were kind of elongated plaques, and all the ones I saw were in genital skin or perianal skin. And some of the things that help me is, in addition to epidermal hyperplasia, kind of psoriasiform elongated redi, even though it's really thick, thicker than regular secondary syphilis, you still get that long redi like you normally get in syphilis. Tons of plasma cells, although remember, in genital sites, plasma cells are pretty common in the dermis in a lot of settings, but it's always worth thinking of syphilis. And this up here, the few cases I've seen, this was pretty characteristic. A lot of neutrophils up in the epidermis, and there's edema and pallor and kind of a ballooning degeneration, almost like the ballooning degeneration you see like in hand, foot, and mouth disease. So those are clues to think of. I totally agree. If I had this case, I would definitely do a fungal stain here. I might even do a gram stain to see if there's some degree of bacterial impetiginization, and do a spirochete immunostain. Or if you don't have that, you can do one of the silver stains like Steiner or Worth and Staria, although, as we'll see a little later, I find those incredibly challenging to interpret technically. So this is Condyloma lata, variation of syphilis, and I think I've got... Oh, no, I'll show you a picture later of what the staining looks like for spirochetes and syphilis. Okay. Case 5. Also something I don't see very often in practice, thankfully. We got a big circle here. That's probably important. But what'd you guys think about this?
I can take this one. So it looked like we were kind of deeper down in the fascia and fat.
Good. Yeah, right here we got a band of thick collagen, right? That's fascia. Excellent.
And then there is some inflammation, and it looked mainly neutrophilic.
Let's see. I think we have some in here.
So putting those two things together, I was thinking of like a necrotizing fasciitis, something that could cause inflammation that deep down.
Excellent. Yeah, that is exactly what this is. And necrotizing fasciitis is a really serious disease that requires, quick intervention clinically, often extensive surgical debridement in addition to antibiotics. One big problem that happens more on the clinical than the path side is that pyoderma gangrenosum is often misdiagnosed clinically as necrotizing fasciitis. I think a big part of that is because a lot of pyoderma gangrenosum is kind of an unusual and relatively uncommon. I mean, I've seen a lot of it, but a relatively uncommon disease compared to other things. And I feel like there's not a great general awareness of pyoderma gangrenosum and its ability to mimic necrotizing fasciitis. So I always showed it to my medical students when I ran a musculoskeletal and skin course in the past, and showed them, look how extensive this looks. You'll think it's neck fasc, but the rolled borders and the history of recurrent kind of, ulcers that begin to heal up and then break down again should really make you think about this, and you don't want to do surgery. So anyway, I think that's always important to keep that in mind, and I always encourage my medical students that if they weren't in derm, that they get a derm consult, because I feel dermatologists are a lot more familiar with PG and can usually recognize the features. But what we see and what we want to see to make a diagnosis of necrotizing fasciitis, in addition to the right clinical, and sometimes on imaging there'll be gas in the tissue, like from gas being produced by the bacteria, depending on the situation. But we will see necrosis and death of skeletal muscle and or fascia, usually both together, and a bunch of neutrophils and debris. So here's, even though this is a little out of focus in here, this is all degenerating, dying skeletal muscle and neutrophils in here. You can tell it's skeletal muscle because look, the nuclei are around the periphery. So these are still alive, but not very happy. These are beginning to die and break down, and there's neutrophils. Going over to the fascia, it's all dead. See how pink and pale it is? That's not just because it's a pale slide. This is completely dead. There's no nuclei left. Completely necrotic fascia, necrotizing fasciitis. In here, not much inflammation, again, because everything's dead. But what we do see is all this blue hazy debris. Those are sheets of bacteria. Tons and tons. So almost always, again, I've only seen a few cases, but really what I want to see is extensive necrosis, and it almost always goes hand in hand with tons of bacteria growing right in the midst of the dead fascia and dead skeletal muscle. And making this diagnosis is important. Again, it's a rapid, really a serious thing. And so it's important. So here's two pictures I'll show you that are a little bit more clear. This is all dead skeletal muscle, tons of neutrophils and necrotic debris. These pics are from my friend Najib Ben Yahya, who's a pathologist in Tunisia. And here's a picture with a variation of H&E stain that he does in his lab that's quite beautiful. And you can see all this debris here and all this fine blue granular stuff. That's all bacteria. So the group A streptococci are one of the big causes of necrotizing fasciitis. The same kind of strep as strep throat, basically. But for some reason, in some cases, it causes this very serious, rapidly progressive infection that can be life-threatening. So that's necrotizing fasciitis, something we rarely see. But this is really good example of what I want to see to be sure that that's what we're dealing with. Okay. And if that's not suspected clinically, that deserves a phone call or other notification so that the treating physician knows, unless, of course, they already suspected that's what it was, which usually I feel like they do. Okay, case number 6.
Can you hear me okay?
Yeah.
All right, sorry, I was having mic issues earlier.
No worries.
So this is another deep sample here.
Yeah.
And you can already see from scan that there's a lot going on in terms of inflammation. Which was pretty nonspecific at first until I found there was one particular area where I found a nice little granuloma surrounding a bunch of neutrophils.
Probably right here once it comes in focus. This is a pretty good one. Here's a rim of epithelioid histiocytes making a big round granuloma, and in the middle, neutrophils, right?
Yep.
So what kind of general differential do you have for this pattern?
So the one that we use is CLATS, which is cat scratch, LVG, atypical mycobacteria, tularemia, and sporotrichosis.
Fantastic. You guys always have great little mnemonics to remember all of the list of things. I love it. Yeah, basically deep fungal or mycobacterial infection, plus a variety of other more esoteric things. So granulomas with neutrophils is infection until you prove otherwise. And if all my stains are negative and cultures are negative, in a case like this, I probably would want to, next step, go to molecular to test for infectious organisms. So you can there's a variety of labs. The Centers for Disease Control offers testing like that. You have to fill out some forms and often go through the state health department to do it. Also, I tend to send stuff to the University of Washington. I have no financial interest in their lab. I've just been happy with what they do, and they can do like a pan, a molecular for either fungus or bacteria or mycobacteria, or for all of them together, and they can test for them. So this case is labeled as a stellate abscess, which is kind of this right here with the granuloma around it. And in this case, it grew out mycobacteria. And so let me show you an example of another one that is atypical mycobacteria. And in my practice, by far the most common mycobacteria I see are the atypical non-tuberculous, non-leprosy types. In my former practice in Arkansas, I saw endemic leprosy transmitted from armadillos a couple times a year. I've personally, to my knowledge, never seen a real case of cutaneous tuberculosis, although I have friends in other parts of the world who see it almost every day. So a real great example of how the pretest probability changes based on the incidence of the disease in our population. So here again, neutrophils with granuloma around it. And in this one case, I remember very vividly, look, there's almost like globi, like you'd see in Lepromatous leprosy, these little circles filled with, you can even see the little filamentous kind of elongated rods here. And they were positive on a phyte stain. So these are kind of long. I feel like a lot of times the atypical mycobacteria depends on the species. You can't tell for sure what species, of course, on the phyte stain. But I feel like atypical mycobacteria tend to be a little longer than what you'd see in TB or leprosy. But again, I'm probably not nearly as expert on that as other people are. So this case, and that patient right here was immunocompromised, I remember. And he didn't actually have much granuloma, just neutrophil abscesses. So sometimes you usually think of granulomas for mycobacteria, which you do usually have with or without neutrophils. But sometimes you will actually not have much granuloma if you don't have good cell-mediated immunity. I think this grew out Mycobacteria kansasii, if I recall, but it's been a long time ago, so I might be wrong about that. All right. Okay, case 7. Once it comes in focus there. All right. Who wants this one?
One. There were a lot of like open spaces here that had little, look like organisms in them. And when I think of that, like the most common thing I think of would be like Leishmaniasis, but you could also have like histoplasmosis, which would be less common in the skin. So I'd probably favor Leishmaniasis.
Well, I suppose it depends on where you live. I don't know, maybe not here, but where I used to practice in Arkansas, I saw histo in the skin. I don't know, maybe not often is not the right word, but multiple times. And leash, the only case I ever saw was one sent to me as a consult from like a soldier returning from the Middle East. So kind of, again, the incidence changes depending on what your patient population is like. I think you're totally right. When you see spaces in the dermis, a bunch of histiocytes and neutrophils, but you see spaces in the dermis filled with little small tiny dots of organism, little tiny round dots. The two main things to think of is Leishmaniasis and histoplasmosis. And people say, oh, you can tell them apart because one thing, leash tends to do this. It lines up around the outside of these vacuoles, right? People call this the marquee sign, like the lights around the sign on an old-timey movie theater, I guess, or like a Ferris wheel, right? Whatever you're into. Whereas you're supposed to not see that as much in histo. I have seen histo that did this though, okay? Maybe not quite this good, but the point is I don't personally feel like that alone is a reliable way to tell them apart with certainty, okay? The other thing is that you're supposed to see kinetoplast. Now, there ain't no way you're seeing a kinetoplast on this scan slide, but I'll tell you what, even in the best circumstance, I cannot definitively see a kinetoplast on a 40x view on my microscope. I'm admitting it right now. What someone told me, Bobby Pritt, Dr. Bobby Pritt, who's an infectious disease pathologist at Mayo Clinic, really smart. Her name is also Parasite Gal online. You can follow her on Twitter and Instagram, and she's got a wonderful blog about parasites and infections. So she said that usually the kinetoplast, you need oil, 100x oil to immersion to see. And she also mentioned there's a stain that you can do that has it's a variation of H&E that has silver addition to it that makes the kinetoplast stand out. Other times people also talk about Giemsa as being positive. Giemsa is a stain like that's used in the right Giemsa stain in Hempath. So it's that Giemsa will make these stain, but also Dr. Pritt helped. I learned this all from Twitter from her. Says this is one of the reasons I use Twitter is I teach, but I also learn from it. That she said that Giemsa really works best on smears. In some parts of the world where leash is very common, like the Middle East, it's easier to just cut the lesion open and smear some of the exudate onto a slide, and then basically you're doing a touch prep, kind of cytology preparation, and look for organisms. And she said that Giemsa works best there, does not work as well on tissue sections. So I thought that was good. I'll also tell you one of the best things that I found is do a GMS stain, which to my knowledge should not stain leishmaniasis, but also histo, which looks very much like leash. Suddenly, when you do GMS, it changes. You can see that they're little tiny organisms about the same size, but they have budding. And leash shouldn't have budding, again, as far as I know. I've not seen tons of cases of leash, but I find that GMS has taken cases that I thought looked really like leash, and then suddenly they look much more like histo once I stained them with GMS. So I find that to be quite helpful. But yeah, that's your main differential is leash and histo. And of course you can do culture. Histo will culture out, leash will not. You can look at the history, travel history, and where the person's from. There's antigen tests to test for histo that you can do, I think, on urine and maybe on blood. I'm not sure. So there's a variety of other ancillary techniques, but the main thing is when you see little holes with small round dots, histo and leishmaniasis. In this case was leishmaniasis. Now this is a great one. Something I've never actually seen in practice, or at least not that I've recognized. Who wants this? Number 8.
Oh, interesting.
Oh, now you're like, oh, the thing I thought it was can't be.
I don't know about that. It looks like very sick tissue. Like I think the epidermis came off.
Yeah, totally detached. You can see the festooning, right? The little papillary dermis is there, but the epidermis is gone.
And then the tissue here looks pretty, I don't know if it's like devitalized, but then there's these vascular structures throughout, and then there's a bluish haze.
So you do know what it is. Good. So what is it?
So there's not, one thing to look for is inflammation, and there's really not too much. And with that blue haze and lack of inflammation, and the blue haze being around vascular structures, you can think of ecthyma.
Yeah, Ecthyma gangrenosum particularly. There's other form of ecthyma, which I think is staph or strep, if I recall, kind of punched out necrotic eschars in the skin. And this, my understanding is that this is more common in like HIV or immunodeficiency setting. But again, I've never actually seen it in real life, just in study sets and educational material. Excuse me. The key is that the skin begins to die, right? So this is maybe not quite dead yet. Like to paraphrase Monty Python here, but this is not happy tissue, right? This is on its way out. The epidermis is died enough that it detached and broke free and sloughed away. The dermis looks like it is on death's doorstep, and the vessels are surrounded by that thick blue coat of Pseudomonas aeruginosa bacteria. You can't see really the individual distinct bacteria here. I'm not even sure if you can on a gram stain. Again, I've never actually seen an example of that. But my recollection is that Pseudomonas organisms are quite small. And so, gram-positive cocci are hard enough to see. And I would imagine that Pseudomonas individual organisms would be even harder. Here's the tissue on the other side. Again, look at that blue haze. Very, very good example of what this is supposed to look like. Let me show you one other case that's really nice from Path Presenter. And this is courtesy of Dr. Raj Singh. I believe he's the one who submitted this case. And so, again, dead and dying tissue. The epidermis is sloughing away. Tons of hemorrhage in this case here. Looking at the vessels. Exactly like what we're seeing in our case, right? Blue haze. So that's the finding that you really want to look for, is that bluish, hazy material around the vessels with the necrosis and, of course, the proper clinical setting. Ecthyma gangrenosum from Pseudomonas aeruginosa. Good work. All right, case 9. Well, this doesn't look like skin, does it? What is this structure? Oh, come on. I'll edit it out if you're wrong. What's that?
Looks like a node.
A node. It is. It's a lymph node, right? It's a blue round structure. And when you go closer, you can see that it's made of lymphocytes. in sheets here, and, well, maybe not sheets. I'm sure a hematopathologist would chide me for saying that, in a very organized way, and nice germinal center formation there. So this is a lymph node. Good. And it's got a fibrous capsule around the outside, and usually you can see a subcapsular little sinusoid there, which is another clue to help you know that you're dealing with a real lymph node rather than like a reactive lymphoid tissue. So here, see that? Fibrous capsule, subcapsular space, that's called a sinusoid, and then the lymph nodes inside that. So this lymph node, and I know you guys don't see lymph nodes really ever, probably, but this is not normal. These structures right here do not belong, okay? The rest of the lymph node to me looks like a big reactive lymph node. Again, I'm not a hematopathologist, but what are these structures? And I think you know these because you can see these in skin too.
Another stellate abscess.
Absolutely. And these big granuloma with a big abscess of neutrophils in the middle. And you already mentioned earlier, you guys mentioned what the differential is for this. Particularly when we see this in lymph nodes, one thing to think of is, anyone know? Yeah, cat scratch specifically. This is like, I'm sure it could be other organisms could cause this, but to me, like the only times I've seen this in a lymph node, it ended up being cat scratch disease. So I feel like it's very distinct. These, like the granulomas packed full of tons of neutrophils in lymph nodes, going to really be a strong indicator for cat scratch. And you can supposedly see the organisms on, I think, Werthen Starry or Steiner, a silver stain. Again, I find those really difficult to interpret. You can do molecular to prove, and Bartonella Hensley being the usual causative organism, although I think maybe rarely Bartonella quintana can cause it. If I feel like I've read that before, but Bartonella Hensley is the most common cause, and you can sometimes see this in the skin itself, particularly like at the site of a cat scratch, like an infected cat that scratches someone. They may get the swollen node, but also they may get some granulomatous response like this in the skin, and I believe some people have called that Bartonella inoculosis or Bartonella inoculation site changes, that it's like getting that same response right where the cat scratch occurred. And I've seen a case of this actually where it clinically the lymph node was so large they thought it was going to be a sarcoma, and it went to a sarcoma surgeon who took it out, and instead it was like a antecubital, so not a typical lymph node. I mean, there are lymph nodes sometimes in the antecubital fossa, but it's not a site where you think of a node right away. And it was a pretty big one, like, I don't know, 4 centimeters, 5. I mean, it was good size, and this is what it was. And we did molecular, and it was Bartonella Hensley. So pretty cool. And that was great news for that patient because easily treatable and curable disease. Cat scratch disease. All right. Now, this looks like a lymph node, kind of, right? You can see germinal centers from outer space. I mean, they're ginormous. But what's this and this?
It's like epithelium.
Yes. When you see a lymph node, that's partially covered by squamous mucosa, right? It looks like epidermis, except it's got kind of some pale glycogenated cells and no stratum corneum and no stratum granulosum, right? So that's squamous mucosa. Squamous mucosa on top of something that looks like a lymph node means you're aware. And I know this is not fair because it's not skin, but do any of you know?
Could it be a tonsil?
It's a tonsil. Very good. To me, that's the way I learned it as a resident. A tonsil is like a lymph node, but covered with or having some invaginated. These are actually crypts. See, this is not the outer surface here. These are invaginated cystic spaces lined by squamous mucosa. So those are the crypts, the kind of infolding of the tonsils. And here in one of these crypts, we see some large structures. And what are these? They're kind of in, like, organized in rings almost, right? So they've got kind of a center and then a ring of purple around the outside.
Yeah, so these are the we've seen the actinomycosis, like the little lumpy grains that we see in that.
Exactly.
The splendor Hopley phenomenon, everything in the periphery, and then you can see the bacteria as well.
Yeah, it's kind of hard to see on here, but there are little thin filaments here, much smaller. What other things can make structures kind of like this? You're right. This is basically what the sulfur granule is in a draining sinus from actinomycotic mycetoma. In these cases, this is actually kind of basically a variant of normal. This is actinomyces growing in the tonsillar crypts. Some people call these tonsil stones, I think is a term that gets used for them. But basically, this is relatively common finding in tonsil, and in my way of thinking of it, it's not really representative of like a serious disease-like process. Whereas if you see this elsewhere in the body, like in the skin or the subcutis or something, then that indicates like an actual active infection. But this is kind of like a almost commensal type situation, I think of. I don't know, maybe someone else will disagree with me. But in the tonsil, we see this a lot. But so what other things can make this sulfur granule type structure?
Well, I know you can have like a eumycetoma where it's like actual bacteria, actual
fungus, right?
That causes similar sort of phenomenon.
Very good. That's exactly what I'm getting at. The kind of three main things I think of that make these globular structures that often have splendor hopli around the outside is actinomycotic mycetoma, which is not actually, if you think of mycetoma as being fungal, like a fungal nodule, actinomyces isn't really fungus, right? I think it's more thought of as a filamentous bacteria now. Actinomyces can do this. I've heard that nocardia can do it, but the rare times I've seen nocardia, it did not make nodules like this, so I don't know. But this is another example. This was actually an infection in the mucosal lip, and you can really see that bright pink splendor hopli phenomenon, which is basically antigen-antibody complexes depositing all around the edge of this nodule. And in this one, you can kind of see right here the thin bluish thread-like filamentous structures, way too small to be fungus. And you can use, GMS and gram stain to help you sort out whether you're dealing with bacteria or fungus, but usually the fungus is going to be, they're bigger. These are so thin that you can barely make out. I don't know on your end if you can even see, because sometimes the resolution through Teams is not as good, but they're very, very thin threads. I love this case because the splendor hopli, just wow, so dramatic and amazing. And there, look, there's the draining sinus tract where it's draining out to the surface of the mucosa in this case, or the skin. Okay, so this was an actinomycotic mycetoma. Eumycotic, U means like true, basically. True mycotic mycetoma is actual fungus making a ball-like structure like this. And the one other thing that you can have, we'll talk about later because we have a case of it here to look at today. So this was actinomyces in a tonsil in this case. Okay, 11.
All right, so even from super low power, you can see a really atrophic epidermis and then a little bit of a gren zone, and then the dermis is just replaced by like a sheet of inflammation.
And what kind of cells mostly would you say these are?
So histiocytes,
right.
When you get even in a little bit closer, you can see that their cytoplasm has kind of some bluish gunk within them, so it would fit with globi, making these fertile cells for Lepromatous leprosy.
Very good. This is sheets of histiocytes with a kind of pale, frothy, kind of loose-looking cytoplasm, and then they have those little empty holes or spaces like vacuoles filled with, all of those are going to be Mycobacterium leprae organisms. So this pattern is very distinct for leprosy, particularly the Lepromatous form of leprosy. You could even argue that this one might even classify as histoid leprosy, which is when it basically becomes like a fibrohistiocytic pseudotumoral response to leprosy. And let's see, I've got a couple pictures here. I forgot to show you, this was earlier. There's Leash, a good picture of Leash in a close-up view. But see, even with all the photo editing in the world, it's still hard to really capture them without oil immersion. Here, this is a leprosy, and it's tracking along nerves here. And here are plasma cells, which I find to be actually a really useful clue for leprosy. And a little tiny nerve in the middle here. And then here's the pale frothy histiocytes, and there's a globus right there, or globi, plural. That's a globus, that's a globus, that's a globus, and all that blue fuzzy stuff. There's another one there. I forgot to put an arrow on that one, I guess. And look at that, loaded on phyte stain with acid-fast bacilli. And here you can see a nerve. And they're right in the nerve itself, actually, around the perineurium, in the cytoplasm of the histiocytes. everywhere. And Lepromatous leprosy is multibacillary. That's the other kind of classification scheme you can use, is pausibacillary and multibacillary, which I kind of like that actually because I think it's a little more simple. The Lepromatous form tons and tons of organisms, as opposed to the tuberculoid form, which is usually pauci. Pausibacillary has few organisms. So this is Lepromatous leprosy. And of course, as you guys know, there's all this borderline Lepromatous, and I've always found that much more complicated, and it really, to me, depends kind of on the clinical situation. This is a great example of something we don't see very often. Case number 12.
So we are on acral skin, thick compact stratum corneum, and then the very superficial part of the stratum corneum is very like jagged and ratty looking.
Yeah.
Which kind of makes me want to go in and see if I can find some organisms there. The rest of the epidermis look pretty normal, not really inflammatory. And then, kind of going in closer, we can see there's a ton of bacteria kind of right up in the superficial stratum corneum. So, pitted keratolysis. Yeah,
this is pitted keratolysis. The organisms here, which I believe Corynebacterium is the most common genus, but I think some others have been implicated occasionally too. And what basically happens is it's superficial infection by these Corynebacterium. This is where the corneum used to be, and these little pits have been eaten down, these little holes. So like you said, perfectly described, an indention with jagged edges and little clusters of bacteria that usually, from the few cases I've seen, you can see on H&E. And I believe this is most common on the plantar foot in like kind of hot, humid, tropical type climates. So probably kind of something to do with occlusion and then the environment, and then the bacteria grow there and begin to eat in. And clinically, it makes a scaly kind of, change to the foot with all these little pits and holes in the corneal layer. So pitted keratolysis, kind of an unusual and interesting form of bacterial infection. Here's more organisms over here. The organisms, again, from the few cases I've seen, very easy to identify. You can just go see them right on H&E. They look almost like Erythrasma, right? These ones do. They're like little linear. Those look a little more clustered, but it's kind of like a florid case that looks like Erythrasma because it's Corynebacterium, but it's on the plantar foot usually. Okay, excellent. Case 13.
This one has a pale kind of epidermis, so it makes me think of like mucosal surface.
Good, mucosa, yes. So let's say vulva.
Okay. And then this one has pseudohyphae in the stratum corneum, some of which they're really hard to see, but they're running north to south.
Yep, up and down, right? Kind of vertical. Good. Here's some right here. There's a hypha or pseudohypha. How do you know if it's a true hypha or a pseudohypha? I don't know. There is no answer. I'll tell you the answer I use. If I want it to be Candida, then I say, oh, it's a pseudohyphae. There are pseudohyphae there. If I want it to be something else, I say, oh, they're true hyphae. That's the honest truth. I do not think morphologically that the hyphal structure itself is different, or that I can tell, oh, it's a pseudo hyphae rather than true hyphae. And I actually found out not long ago from reading in the literature that Candida can actually produce true hyphae in addition to pseudo hyphae. Some mycologists will have to explain to me how you actually make that distinction, like what the technical definition is. But I feel like on light microscopy, I cannot recognize the difference between those. I can, however, think of some clues for candidiasis. One, like you said, is the hyphae doesn't always work, but they tend to be vertical north and south. They dive down into the epidermis, whereas dermatophytes kind of surf along the waves, okay? And you also, one other thing that really helps me is when I see the hyphae here also, sometimes you can see them actually pierce into the viable portion of the superficial stratum spinosum, okay? And that actually on cytology, like from cervical cytology, like a pap, when you see Candida there, you tend to see Candida like kind of skewering and stabbing through multiple keratinocytes. And I think this is kind of analogous to that. I feel like you do not usually see dermatophyte fungus grow down like this, whereas Candida, sometimes you will see it, but not always, okay? The main thing I have trouble telling is, the one other thing that's helpful is that Candida has both yeast and hyphae or pseudohyphae, right? So you'll see elongated hyphal or hypha-like structures plus yeast, okay? Yeast forms. And the other thing that can do that, though, dermatophyte does not make yeast, right? It's not a dimorphic fungus that makes yeast. It's not a yeast. It does sometimes have little round structures, spores or conidia, but you don't see that. I've never seen that, at least in dermatophyte on the skin surface. You see that like in endothrix and ectothrix type dermatophytosis. But the other thing that can give you hyphae and yeast is going to be Tinea versicolor, right? Malassezia or pittosporum. And the other clue I like for both for Malassezia and Candida is they're usually bluish purple and easily visible on an H&E stain without even needing to do a fungal stain. Whereas I showed you earlier, dermatophytes usually, at least in the H&E preparations I've used in the labs I've worked in, they're usually clear. I have seen some that were bluish dermatophytes, but most of the time dermatophytes to me look almost totally invisible and clear. You just see the little clear spaces they leave, whereas I can almost always easily see on H&E Candida and dermatophyte. So then, Candida and Malassezia, Tinea versicolor. To me, the biggest distinction is where are we on the body? If we're on the vulva or the lip and I see hyphae or pseudohyphae plus yeast and they're bluish purple, then it's going to be Candida, right? If we're on like the mid back or the chest dry skin, then it's almost certainly not going to be Candida. It's going to be Tinea versicolor. If I'm really not sure, I say that there's fungal organisms and that, it could be this, but, it could be Candida, but, dermatophyte or Malassezia would enter the differential. And if, that way, make sure you treat it with something like, ketoconazole or one of the drugs that will cover broadly the fungus rather than like nystatin, which will just, cover Candida, but not cover dermatophyte fungus, right? So if I have any doubt, I'll just say there's superficial fungi, and then I'll tell you which one I favor. But in any case, those are some clues and tips to telling those apart. And I do have one really nice example of beautiful vertical diving in Candida that I saw not too long ago. Look at that. There, this was a vulva, and you can see perfect north-south vertical purple fungal hyphae in the corneum, and look, some yeast also. So this is a really nice example of candidiasis. I'm very, very happy with that picture, I have to tell you. I've been looking for that good of an example for years, and I finally found one. All right. Okay, next is, look, we're just going to skip over this one or go really quickly. I'm not going to ask you. This is a rabbit testes, and the rabbit testes can grow spirochete organisms and can be used, I don't exactly know how this is done, but this is used as control tissue for syphilis, because getting actual, samples of syphilis, thankfully it's becoming, even though the cases are rising nowadays, it's still not something that we have tons and tons of extra tissue on hand. This is why I don't like Steiner and Warthin-Starry. There are black little spirochetes in here, but there's so much background stain. And I have seen examples that were very good. I think it's somewhat dependent on the lab and the skill of the histotechs in doing this. But because these stains are not used very often anymore nowadays, I feel, in many labs, I feel like a lot of techs probably don't have regular experience doing this. And so getting an optimized perfect one, to me, is really hard. So I personally essentially never use these stains. And I've heard other people argue that I should, but I have to tell you, I just feel like it's so difficult to interpret. There are spirochetes here, but they're really hard to see. Now, let me show you what the spirochete immunostain. And not everyone is lucky enough to have access to this, but this is what the spirochete immunostain looks like. No doubt about that, right? This is with a red chromogen. You can also use brown. Red sometimes has this little fine granular background that's nonspecific. Brown, sometimes the difficulty is telling apart melanocyte dendrites from the actual organisms. But look, right here along the stratum, the basal layer, you're seeing numerous squiggly little linear spirochete organisms. And here's a close-up view to see that they kind of have that spirally, twisty shape. That is an example of secondary syphilis with a spirochete immunostain to recognize the Treponema pallidum organisms. Okay. All right, what's this one? Case 15.
This one in the dermis, there's a purple glob.
It's coming in focus here. And where are we, probably? What's this?
Cartilage.
Yeah, cartilage. Exactly. So we're probably on the ear, Maybe the nose. Gosh, I hope not. That's a big piece if it's the nose. But I would imagine we're on like the helix or somewhere. I don't know. I don't have any history on this case, but that would be my guess. All right. And yeah, here we got some neutrophils, and right above the cartilage, a purple blob with a little bit of pink layering around the outside. So what is this?
Bacterio.
Yeah, botryomycosis. And so what is botryomycosis actually? Do you know?
Like a clump of staph.
Good. And I wish I could get you to see them better, but that's what you're seeing here. These are actually little aggregates of 2 or 4. Sometimes they make little kind of square shaped clusters of cocci. And on this scan, it's really difficult to see, but in real life, usually when you look closely, you can see that rather than the long filamentous structures of Actinomyces, or the actual fungal hyphae of eumycotic mycetoma, in botryomycosis, you're getting that same kind of sulfur granule look, but the structures it's made of are cocci bacteria. So this is a confusing name because botryomycosis sounds like it should be mycology, should be fungus, right? But it's not. It's actually a bacterial infection, but it produces that same kind of mycetoma-like sulfur granule. They tend to be, from the few cases I've seen, much smaller. This is actually one of the bigger ones I've seen. The ones I usually have seen in practice, you'll get like 1 or 2 of these tiny little granules. They sometimes are very hard to find because they're so focal. You got to get just the perfect cut. But then what you do is you zoom in to see if they're made of cocci, and if they are, then the answer is botryomycosis, which, as you said, is due to gram-positive cocci bacteria. Here's a picture from my friend, Dr. Patrick Rush, great dermatopathologist, and you can see a little more clearly these are little cocci, and they're clustered together, and they often have that pink splendor-hopley phenomenon around them. They don't have to, but they often will have that. Just like any sort of foreign, growing cluster of organisms tends to produce that phenomenon. Okay. I'm trying to move quickly here to get them all done and not make you guys late. All right, case 16.
So this one, when I was just looking at it at first, I thought that maybe the stratum corneum looked a little suspicious because it was a little compact. But
Sure.
There's other stuff going on too. There's also a bit of a interface kind of change along the epidermis, and then some elongated reedy ridges. I think maybe there were some plasma cells in the infiltrate, so possibly a syphilis.
Good, excellent. And you're right, that this is actually really tricky because I think at first glance you could kind of think it's sponge, or maybe think it's like a vacuolar patchy lichenoid infiltrate, but it's not a lot of infiltrate here, right? This might be the most exciting thing at first glance, and you could definitely think a dermatophyte or the other things we talked about that give you compact stratum corneum. But the reedy are a little elongated and thin, right? The thin little leg-like reedy, and then there's kind of a patchy band of lymphocytes. A lot of times in syphilis, secondary syphilis, you'll see the elongated reedy and a thick, very lichenoid band. But here, it's much more sparse in inflammation. Syphilis can really it's the great deceiver, the great mimicker for a lot of reasons, right? Both clinically and microscopically, it can have a wide range of presentations. I do a syphilis spirochete immunostain way more often than I actually find syphilis. So, I don't know what my ratio is, but it's a rare time. I order spirochete stain on a regular basis, and only rarely does it end up being positive. But some of those times I was really not suspecting syphilis. And because this is a disease that is bad if it's left untreated, it's easily treated, it's sexually transmitted, there's a whole bunch of reasons that we really, really want to try to avoid missing this. So whenever I see plasma cells around vessels, I think of syphilis. Whenever I see a lichenoid kind of band, especially when you see, a normal lichenoid or vacuolar interface should have a lot of dying keratinocytes. I feel like in most cases of syphilis I've seen, I get that interface pattern of inflammation, but without the actual dying keratinocytes. So I find that helpful. A lot of times you get a lot of lymphocytes getting up into the epidermis also, kind of trickling up into the epidermis, but again, without dying keratinocytes to go hand in hand with it. So the psoriasiform elongation plus a kind of lichenoid band, think of syphilis. Plasma cells around vessels, think of syphilis. I don't know if you can really see it here, but the endothelial cells kind of get plump and swollen in syphilis as well. Let me show you a couple more pictures to give you an idea of the range you can see here. Here we go. And this one was a really florid example. Thick, lichenoid band. Almost you could start thinking of lymphoma. In fact, I think this was a case that clinically they were worried either infection or lymphoma because it was so florid and the lesions were so indurated and juicy. Perivascular, superficial, and deep is really helpful. Obviously on a shave, you can't tell that. But superficial and deep perivascular with plasma cells, lichenoid band with elongated reedy, think of syphilis. And here's that example, like, look, it's a thick band, but not very many dying keratinocytes to go with it, and a lot of lymphocytes trickling up into the epidermis. Closer look, you're going to see plasma cells down in here usually. There's plasma cells, and the endothelium, you can barely even see where the vessel is because they're so, these are the endothelial cells here. They're so plump and swollen. If you have trouble recognizing that, don't feel bad. I feel like that took me a long time to really get more comfortable with seeing swollen endothelial cells, or in fact with seeing all the vascular changes we talk about in pathology. I felt learning the patterns of blood vessels was a skill that I really didn't begin to get comfortable with until early in my practice. Even after fellowship, it was something I still struggled with. So I think it takes a while. And then there again is the spirochete immunostain. And I have seen a few cases that had no epidermal change and just perivascular lymphs with plasma cells. So if in doubt, do the stain or recommend RPR or additional testing if there's any doubt clinically, okay? And I'm going to just skip past this one, 17, because I personally could not find the organisms. This is supposed to be nocardiosis or nocardia, and I will just show you one example. I've only rarely seen nocardia. Here was an example I saw. This one had extensive necrosis and tons of neutrophils. Obviously looked like infection. This patient had multiple ulcerations of the leg. I think they were immune compromised, but I can't recall the exact story. So obviously we were highly suspicious for infection here on this case. And then here, this was the gram stain. Look at these long filamentous gram-positive rods with a kind of almost beaded appearance, I believe, has been described as being one of the features you see. And they can also be weakly acid-fast as well. Although I think I tried that in this case, and it was difficult to work, but culture in this case grew out nocardia. So this is one of the rare times I actually have seen nocardia. And as you can see, there's a lot of organisms, but they're not making like the mycetoma sulfur granule, at least not in this case. So that's nocardia. And now this is case 18.
So here we have punch, and you can see that it's predominantly a peri-eccrine and neural lymphocytic infiltrate.
Yeah, and this is kind of hard because right here it's all lymphs, right? I mean,
right. You know, like whenever I think perineural, obviously in the section we're in, I would think of leprosy, but you know that would be more histiocytic.
So
and with the
yeah, sorry, keep going. I apologize.
So with the lymphocytes, then I'm kind of like in my superficial and deep differential, and that could include lupus. It could include Lyme, which would be infectious. Also, I guess you would consider syphilis because it's a great mimicker.
Yeah, and also things I see, I feel like I see peri-eccrine lymphocyte aggregates also in perniosis, which of course has a lot of overlapping features with lupus sometimes. And I've also seen it in bug bites, although you would expect to have a lot more inflammation up top too, and a lot of EOs, but I feel like I often see peri-eccrine lymphocyte aggregates. This, I think, is a really hard case because there might be a little tiny granuloma here, but boy, it's subtle. And there's, I mean, up here, there's very little except right over here. There's one granuloma, and it's around a vessel. A perivascular granuloma is basically a perineural granuloma until proven otherwise. We know that in leprosy, we tend to get granulomas around the nerves. Well, remember, nerves and vessels, even at the small level, track alongside one another. So anytime I see granulomas near a vessel, I suspect that there may be near a nerve as well, even if I can't really visualize the nerve itself. So that's one little clue to always think of. And here's one that I think is actually around a nerve more obviously. Right here, this little slightly wavy collagen structure in the middle probably represents, I can't be sure on this scan, but I bet you this is a small nerve, and the perineurium is totally distended by histiocytes, right? So this is kind of a tight granuloma, tightly cuffing around the nerve, and it's kind of linear and elongated. That's classic for leprosy, tuberculoid or pauci bacillary leprosy usually. And here, let me show you a couple examples. This is an example of tuberculoid leprosy. The granulomas are much more obvious here, and the cells are linear or serpiginous because they're tracking along neural structures. and around vessels too. And they tend to be much more dense cytoplasm, less of that loose, fluffy cytoplasm like you see in Lepromatous leprosy. They're kind of almost sarcoid-like granulomas. Here, there's a nerve right here, and they're wrapped, a sarcoidal granuloma wrapped around the nerve. I will point out that publications in the past few years, or maybe it's been a little longer than that, have shown that you can actually have perineural granulomas in sarcoidosis also. So this is not definitive for leprosy, but if I do this and I do a stain and I don't find organisms, I usually will send this for molecular testing to further exclude the possibility of leprosy. And in the end, if everything we've done doesn't find organisms, then I would recommend that the clinicians treat this with, like they would treat sarcoidosis, and obviously do additional clinical workup to see if the lungs are involved or whatever, but try to use, immune suppressing drugs to see if the granulomas get better. If the process gets better, well, guess what? Probably it was sarcoid or some other reactive granulomatous process, not leprosy or infection. If it gets worse, then stop the steroids or whatever treatment you have them on and do another biopsy and see if organisms are there. And that was a kind of the basic approach that was given to me by a leprosy expert, actually, who has seen many, many cases, said that that's how they deal with it when they've done the fight stain and it's negative, and they've done molecular and it's negative, because sometimes in tubercular leprosy, the organisms are so sparse that you can't see them, and even molecular won't be able to detect them because they're so rare that there's just not enough nucleic acid there to amplify. Here's another example from low power, and you can see how linear the granulomas are. But this one, when you get closer, even though it looks linear like that last one, the granulomas, the histiocytes have a more frothy, loose cytoplasm, and you begin to see globi. So this was Lepromatous, and Lepromatous often can make sheets like we saw in our case earlier, but don't be surprised that sometimes it can make this cyprigenous granuloma pattern. The difference is that the cells of these cyprigenous granulomas look different than the tubercular leprosy, where they're real dense pink. And I know it's a little bit subtle at first. The easy thing is when you do the fight stain, if you see one or a few organisms, probably tuberculoid. When you see 1,000 organisms, it's going to be on the Lepromatous multibacillary end of the spectrum, like right there. Okay, just a couple more, and then we're done. Okay, what's this one? Acral skin. Looks like normal almost, doesn't it?
So this was just like what you said, acral skin with normal skin, but in the stratum corneum there were pigmented hyphae.
Good. There they are.
Tinea
nigra. Tinea nigra, which is dermatophytosis pigmented fungi, it depends on where you are in the world, like Ecthyma, I think, where Necrotizing is one of the main ones, but and I'm sure that name will, if you're watching this on YouTube a few years from now, someone will have renamed it by then probably. But yeah, the pigmented fungal hyphae in the corneum. I've only rarely encountered this, even though I used to live in a relatively hot, humid climate, which is where it's more common. I think it's a fascinating disease. Same kind of fungi that basically cause like chromoblastomycosis, pheohyphomycosis, which is basically an invasive infection by these types of fungi. But this can, it can mimic melanoma clinically because it can be an acral pigmented patch that's kind of growing relatively quickly, and so that prompts concern. But I feel like the few cases I've seen were just like this. They had essentially no inflammation. And you could argue the corneum's a little thick, but it's acral skin. The corneum is in general pretty thick there. So I feel like on acral skin, always try to think of this because it can be real easy to miss from lower power if you don't go down and look. And here's one other picture just to give you a close-up view of what the hyphae look like there. The nice tubular, you can see they're pale in the middle. Basically, they look like dermatophyte hyphae, just turn them brown, and you've got Tinea nigra, okay? And then, I think this is the last case.
Some little mounds of hyperkeratosis.
Yep.
But everything else with this power looks pretty normal, like not much inflammation in the dermis.
Good.
When I went in really close on those mounds of ortho hypercare, I could see some little organisms, like spaghetti and meatballs.
Good.
Little spores and short hyphae, kind of that bluish color that you were talking about, so Tinea versicolor.
Yeah, exactly. We're here on the trunk somewhere, and you see bluish hyphae and yeast, well, then it's going to be Tinea versicolor. When you just see the yeast, that I regard as being, some people have proposed that this means it's just commensal. I see just Malassezia furfur, Pittosporum ovale, whichever name you like. I think Malassezia is the current name, but pityrisporum has such a nice ring to it, I think. When you see the little clusters of the Malassezia or pityrisporum yeast in the openings of hair follicles or in anything where there's thick keratin, like over the top of seborrheic keratoses, I see this all the time. And I don't even mention it because those are just commensals growing on the skin surface. But when they start producing hyphae, once you get not just the meatballs, but the spaghetti, that's when you know it's actually probably a spreading eruption and or a spreading infection that's actually Tinea versicolor or pityriasis versicolor, as some people like to call it, because it's not actually dermatophyte fungus and not Tinea. And I feel like the spaghetti meatball appearance is best seen actually on a skin scraping, KOH preparation, but you can sometimes see it in areas where you get thicker keratin because the keratin kind of comes loose and flips, and then you're basically what we're seeing there is the equivalent of what you would look at on a KOH preparation, and you can see little hyphal structures and the little yeast forms. And I feel like you guys recognize this clinically and don't usually biopsy it. The times I see this most often is actually I've seen it over melanoma. Just totally incidentally, I've seen it over top of an AK or a squamous cell carcinoma in situ. So I tend to see this as an incidental Tinea versicolor finding where there's actually hyphae and yeast. In the setting of, the dermatologist doing a biopsy for something else that was the actual lesion, and this was just like a bonus finding. I mean, I just actually had a case of that not too long ago. And here for the final pictures, here's a closer up view of it. Very nice yeast, and you can see they're budding yeast. So when they're round and they're making buds, you know it's yeast. And then they've got the hyphal structures here. But again, I mean, if you said this was the vulva, I'd tell you it was probably Candida. If someone out there knows reliably, honestly, how to morphologically tell apart this right here as being Tinea, being Malassezia rather than Candida, please teach me. Because after looking at many cases, I don't feel like I'm able to do that without using some extra context clues like the clinical information. All right, so there we go. That's Tinea versicolor. All right, guys. Well, we did some fungus and we did some bacteria, and you all did great as usual. Have a great day and enjoy your weekend.